There's a dark symmetry to what's happening in this time of COVID when it comes to life expectancy. The global numbers are, no surprise, falling after several years of stall and splutter. The last time they plunged so much was roughly 100 years ago, after the Spanish flu killed 20 to 50 million people. For all but the life extension radicals, there's a sharper focus now on Healthspan, how long we live in good health, without the chronic diseases of lifestyle, genetic bad luck, and general physiological wear and tear. I'm Susan Flory, and on this episode of The Big Middle, what's happening with Healthspan? This is the terrain of my learned guest, Dr. Rupert Dunbar-Rees, the founder and CEO of outcomes-based healthcare. He's going to tell us all about that as we go. Rupert, hello. Welcome.
Hello. Good afternoon.
Good afternoon. What a stunner of a day, huh? You're in an air-conditioned office. Are you in your central London HQ?
No, today I'm in rural Buckinghamshire, but it's still hot and kind of touching on 30 degrees C out here. I'm not quite sure what that is in Fahrenheit for your US listeners, but it's a lovely sunny day outside.
It's broiling and gorgeous, the kind of day that we all long for in the dead of winter, or even May, which was sort of like monsoon season here in the UK. Now, I want to start by giving you some context, of course, but instead of doing one of those, Wikipedia word wedges with all of your accomplishments and all of your degrees and everything you've ever done and the prizes you've won, I want to just feed you some prompts and you can tell us. First off, you trained as a doctor in the NHS system. You went into the NHS system. How long did you practice as a general practitioner?
So I did, I had a bit of a squiggly career, I think it's fair to say. But once I'd sort of settled on medicine, and that's another story. I started off life thinking I wanted to be a vet, actually, because I grew up on a farm and was surrounded by animals all the time. But I was not smart enough to be a vet. So I went into human medicine. And
human medicine is easier than animal medicine?
Seemingly so, yes. It certainly at the time anyway was less competitive to get into, and maybe they have less going on, less species to focus on, I guess. So I trained in medicine, and then I was a hospital doctor for probably I think 5 or 6 years or so, and then I moved over to general practice, and I was a partner in general practice in the Scottish Borders, beautiful part of southern Scotland, just on the border of England. For about 5 years or so before taking my next career turn.
So why did you decide to quit as a GP?
So I think there was there were a few sort of human things going on. I'd found myself in a job which people normally arrive at in their mid-50s, in my mid-30s, being a partner in general practice. And so I was sort of thinking, a lot of the challenges that I had ahead of me were by then behind me. But also I started getting into and finding out more about how money moves around the NHS and healthcare in general. And I realized that everything wasn't quite right about that. And started getting into the work of a well-known Harvard Business School professor called Michael Porter, who was doing a lot of work on the forces of competition in business originally, but then increasingly in healthcare. I started to get into his work a lot more on value-based healthcare.
Well, and was he one of your lecturers? Because I know you went on to do an MBA in finance and you were selected for a specialist healthcare delivery course at Harvard Business School. And this was what, after you scratched that entrepreneurial itch and set up outcomes-based healthcare?
That's right. It was after that. So I'd left general practice by that point, and I'd had a couple of years at the Department of Health in London, really advising on setting up new GP surgeries, new dental surgeries, and new hospital facilities. And so I'd done that for a couple of years. And for the first time, my first time in my professional career, my boss was not a medic; he was an accountant. So I decided I needed to be able to speak on even terms with my boss. And so I went and got an MBA at Cass Business School in the city. And as part of that, I came across this chap called Michael Porter, who, for those of you who are familiar with him, he came up with this idea of Porter's 5 forces, and they could be applied to any industry, apart from healthcare, it seemed, or at least that was the challenge that was being set for him at the time. We'll maybe come back to that.
Yeah, we will. We'll look at the models and what you consider to be the best the best bits of good practice out there. So how does this connect? How does all of that study and you kind of saying, okay, well, I don't know anything about this, so I'm going to learn about the numbers with healthcare delivery. How does it all connect to what you're doing now at outcomes-based healthcare? Or heretofore, let's call it OBH.
OBH, yeah. Let's go with OBH from here. It's nice and easy because it's a bit of a tongue teaser. So OBH, which is the company I set up in 2013. I say company, it's probably more of a think of it as an organization rather than purely as a company, because we're mission driven, sort of social purpose organization really. And the mission that we were seeking to address is really until really this point, we had been paying for treating ill health rather than preventing ill health, or paying for ill health rather than creating good health. And so much so, in fact, that if health systems, it doesn't matter whether we're talking about the UK here or the US or internationally, certainly in the sort of leading economies, if someone succeeds in prevention, ultimately the provider suffers financially. And so, like anything in life, you get what you pay for, and it seems we only pay for treating, or largely only pay for treating ill health. So that's what we get. And there's very little incentive or focus on, and certainly very little financial incentive anyway, on successfully preventing ill health. And so I suppose that's the problem that we're seeking to fix as an organization, which is really how can we align what matters most to patients, and how can we align best clinical practice with payment and reimbursement in healthcare? So that's the sort of...
We'll get your ideas on what the best systems would be then. But I first want to say, I met you more than a year ago. I was heading up the communications team of a UK task force on longevity, the all-party parliamentary group, the APPG for longevity. And you were one of the many who gave evidence to the APPG, and now you're a member of it in its latest incarnation on a business panel. Your analysis of the Healthspan data was shocking, so much so that became the main takeaway of their flagship report. And, just to remind people, those who don't know, because I've had Tina Woods on a couple of times, the leader of the APPG, the mission statement of it is quite a mouthful. It's to figure out how the government can meet its goal of adding 5 additional years of healthy, independent life for all UK citizens by 2035, all the while narrowing the gap between rich and poor. Now, the Healthspan numbers that you came up with painted a pretty grim picture then, and that was, roughly a year and a half ago. And now you've embellished that picture, because the latest I've read that OBH has done, you've found that Healthspan in England tops out at just 30 years old. Can you dig into that for us?
Yes, gosh, it's a complicated picture, but I'll try my best to sort of keep it reasonably simple. In essence, the main metrics that we have to go on, I guess, are how long people live, so their lifespan or their life expectancy. And typically for a lot of developed economies, that can be in the sort of high 70s, early 80s. And then healthy life expectancy, which is usually based on a survey asking people how healthy or how well they feel. Oftentimes a very small sample size over typically a rolling 2 or 3 year period. And we often find out that data kind of 2 or 3 years after time. So in the UK at the moment, we're reporting 2016 to 2018. So we're still some way off the pandemic using traditional measures, if you like.
And this is still the self-reported, are you generally well? Are you not? Which is, kind of putting a wild card in there, because I guess they can't say objectively whether they're in good health or general. I mean, it's all about defining what general good health means.
That's right. And it will mean different things to different people, of course. But you're absolutely right. It's a self-reported measure. It's universally, it's very widely accepted as an approach to establishing how healthy a population is. But it's really how healthy do people feel. That's how I sort of summarize that, what healthy life expectancy is all about. So our work is slightly different to that. Our work takes objectively recorded clinical healthcare data from different care settings and looks for the presence or absence of significant ill health, significant conditions. And we're talking about things here like coronary heart disease, dementia, diabetes, asthma, COPD. So quite significant conditions, some of which are reversible, but the vast majority are progressive, and if left untreated, can lead to complications. So it's not sort of mild self-limiting illness that we're talking about here. And when we start to look at that kind of data, and so here I'm going to differentiate between how healthy you feel versus kind of how healthy you are. If we asked your doctor, how healthy are you? This is what they might look at. They might say, well, this person has, one or more significant conditions, that we're going to need to keep a significant eye on. So when we look at that kind of data in some of the sort of data structures and data setup that we have in the UK, where we've got a full population coverage with a single patient identifier, and fairly high degree of digitization, when we look at that data, instead of seeing what we see in the surveys, which is typically sort of low 60s, 63 years of age or so for healthy life expectancy, when we look at Healthspan, objectively recorded Healthspan data, on average, it's coming out at sort of 52, 53. And as you rightly say, that masks significant variation. And at the lower end, approximately a fifth of the population have already experienced significant illness by the time they're 30. So
yeah, that's incredible to me. I mean, 20%, 1/5 of the population. But even there, you mentioned 52 and 53. When it was self-reported data, it was always, you might get something around 63. Was it 63 for women, 64 for men? But you found it's 10 years before that. So we're not in as good nick as a population as we would have thought.
Yes, absolutely. And I think they're not entirely like measures, of course, because one is sort of how healthy are you, and then versus how healthy you feel. And so you could say, well, there's a gap between 10 years or so between how healthy people are objectively and how healthy they feel, which is, in some ways that was great. People feel healthy despite living with quite significant long-term conditions. But that all comes at a consequence in terms of poorer health outcomes down the line, greater health expenditure, and so on. And so from my perspective, I think it's really important that we have some leading measures of health that indicate not where we've been, but where we're going in terms of health or poor health, and because then we can start to course correct and start to bring in interventions and see whether they're kind of working in the moment or not, instead of having to wait 2 to 3 years.
Well, what do you have to do to project into the future on the basis of the data that you've collected from the system?
Well, that one's a hard one in terms of projections, because I guess we started developing this measure probably about 5 years ago, and published the first local baselines probably a year or two after that, and then the first national baseline just before the report that you mentioned, the Health of the Nation report. So that was literally just before the pandemic. So we're still getting to grips, I think, with a lot of the baseline data, and still refining the baseline data. So I think in terms of projections, our first step is really just making sure that we really understand the baseline. Do we, understand, how is it changing? And of course, we've had a pandemic since our first baseline. So that's complicated things somewhat. But also, we're starting to see some of the impact, some of the features which appear to be associated with poorer health spans. So if I tell you that the gap between the most and least deprived in terms of health span is typically in the region of 13 to 15 years. But if we look at particular domains of deprivation, like living environment, housing, so access to green space, quality of housing, and so on, that gap increases to 19 years. So there's a gap between the most and least deprived of, nearly 2 decades, when we start to look at sort of wider determinants like housing, education, crime, and some of those sort of aspects.
The so-called social determinants and the environmental factors.
Absolutely. And it's, so I think when we're thinking about, how can we project, how can we understand, how can we forecast what our health plans are going to be, it's often on a lot of these non-health dimensions, I think, which are the most important characteristics which seem to be driving why we first get sick, and what we can do, and more importantly, what we can do about it, and how we can get people back into that sort of healthy, well cohort for as long as possible.
Well, what do you suggest that we do? What levers can we pull? And systemic levers can be pulled because, we've seen this coming. This has been a big focus, preventative healthcare, moving away from pills for ills and disease treatment after the fact, which is the model that everyone's talking about adopting, especially with the rapidly aging population. So what do you see are there any quick fixes, or is it just going to be, lumbering along, trying to tweak things as we go?
So I think in terms of specific interventions, I think there's a whole range of things which, the sort of menu of interventions that can either keep you healthy for longer or get you back into the healthy, well cohort if you become significantly unwell for the first time. There's myriad of examples of things which can help on that score. I think in terms of what needs to be in place for that, though, there has to be some kind of, certainly as far as the funding mechanisms are concerned, there has to be some kind of means of reimbursing providers or reimbursing whether that's, I'm not talking about healthcare providers here, I'm talking about voluntary third sector organizations, whoever it may be, who's got the right combination of interventions, have to have some means of getting funded for supporting you to do whatever it is that keeps you healthy for longer.
Not to interrupt, but this brings me rather neatly right to the homepage of your website at OPH. You pose a what if question, and I wrote it down here. It says, what if health systems were incentivized and paid on preventing disease, improving health, and those things that make a difference to people's lives? I mean, what in your view is the holy grail to that outcome?
Well, I think that the biggest single step that we can make is, A, understanding what is our current health span. B, trying to have a mechanism that allows us to pay for prevention. We don't currently have that at all. We only pay for once people get sick. And part of that is that there just isn't a payment for prevention kind of mechanism. And the reason for that is because we don't know or understand or monitor or measure our health spans routinely or systematically, or we've only just started to. Because then you can start to, once you have a sort of viable metric, you can then say, okay, well, if you're a local health system, what we're going to do is we're going to give you some of your money on treating the sick people who need, emergency treatment and so on, but we're going to give you some of your money on basically improving health span. But to do that, you need measures which are not just one measure. There's different ways of coming at that question, but we do need some way of working out whether you're actually making a difference in respect of extending people's healthy lifespans or not.
Well, it's all about defining it and then figuring out a global way to measure it, which would seem a huge mission.
Yeah, I guess. But so I guess our our mission started there. Actually, it started probably at TEDMed. So I've been going to TEDMed. In fact, TEDMed was where OBH started.
TEDMed, the medical talks from TED.
Exactly. So there's a medical spin-off version of TED called TEDMed, which is hosted usually annually in the US, in different parts of the US, and so it's been hosted in particular DC and Palm Springs, all very nice places to go. But it was actually just at the 2013 TEDMed conference, I think, that I decided that this was going to occupy me for the next few years of my life, and so I set up OPH. But it was at a later TEDMed that I started hearing more and more about Healthspan, and in particular how to extend Healthspan in mice, experimental animals and so on. And it just got me thinking about, why don't we actually have an objective, accurate measure of Healthspan in humans? And so sat out on that mission, came back from TEDMed and said, guys, I think we need to start measuring Healthspan. And of course, a lot of our work to date on measuring health outcomes had been measuring outcomes for people who were already experiencing poor health. So we were doing things like measuring whether people with diabetes were ending up with amputations or heart attacks and strokes and so on. But then there was kind of 50-60% of the population for whom none of that was going on. And we basically we used something called the Bridges to Health segmentation model, which again was this was a conceptual model of how people's life course evolves from being healthy, well, to having one or more long-term conditions, through to the sort of end phases of life. And so we use this model from Joanne Lynn and colleagues at Centers for Medicare and Medicaid in the US, and we applied that to the UK data sets to try and work out, well, who are these healthy, well people, and how old are they, and when do they stop being healthy and well, and why? And can we measure that, and can we see what proportion of the population's life is spent in good health? What's what we call in kind of technical jargon, their health span to lifespan ratio? Because we need to, if we want to be able to afford increasing longevity, 5 extra years, if we want to be able to afford that, those years have to be spent in good health. Because if they're not, longevity starts to become unaffordable if it's lived in poor health. So anyway.
So were you then among the first at OBH to start measuring this, or globally, is there another country that's setting the pace on this?
I'm not aware yet of another country that or region or system that is systematically measuring population level healthy lifespan through objective data. So at the moment, we seem to be a bit of an outlier. And we've now baselined that for England. And we also have slightly more granular measures of that with local health and care systems where we use linked data sets across different care settings, including primary care and GP practices. So we have a sort of daily view, if you like, of how well the population is. But yeah, like I said, I think at the moment, the sort of established way to measure healthy life expectancy is through the sort of survey measures that we were talking about at the beginning.
Is there like a mashup model for healthcare delivery that's pinned on prevention that you could concoct here and now? It had these elements. Once you've got that cohort that are not experiencing these comorbidities earlier than we thought.
Yeah. I think that's still a work in progress, actually, because as I mentioned, it's so multifactorial. It's so dependent on the sort of people's social circumstances, the environment they grow up in, the sort of adverse experiences they experienced as a child and things like that. So there's many routes to significant illness, unfortunately, and unpicking that is not going to be quick or easy. So I don't want to sort of say here's a magic wand and it'll all be fine. But I do think we can create a far better gravity for things that can address those problems to exist in. And if we can do that, then they'll flourish. Because at the moment, if those things, however brilliant, the combination of the cocktail of interventions is, inevitably struggles to survive in a payment system that can only really reimburse treatment for ill health.
Okay. I'm thinking, too, about, that gravity that you spoke of. The work that you do relies on gathering and analyzing NHS and other data. Now, you'll have seen that Twitter hashtag, NHS data grabbing, and howls of outrage and petitions flying around over the government's June 23rd deadline for UK citizens to opt out of the automatic sharing of their health records. Is there a justifiable cause for concern from the people these campaigners who are saying, look, you are surrendering your right to data privacy, could be sold on commercially?
I think this one has got lost in translation, unfortunately. I think it's absolutely right that people are concerned about how their health data is managed. Of course it is. And if they are concerned, then it's a sign that the messaging hasn't been right, at the very least. But I'm confident that behind all of that, the messaging which hasn't been well positioned, and the concerns therefore that people have, there is a very legitimate public health interest in getting this right. In fact, the pandemic has brought this into stark focus by using some of this kind of data, which is being spoken about here. It's only through that we can really understand the actual risk of COVID. It's only through using that kind of data that we can get vaccines into the right arms at the right time and prioritize that. And it's really the only way that we can sort of protect our population, by having this kind of data. Through the shielding actually was the earliest example of this, and it was very chaotic in the early stages of the pandemic, simply because we didn't have the right kind of data of the kind they're talking about. But I think the argument sort of sometimes loses contact with reality, and I think that's because as a system we haven't made a good enough job of articulating the benefits, and really why we, if we want to keep the population safe, we do need something of this kind of data in place, with the proper safety measures in place, with the proper approvals processes. This was never and is never going to be a free-for-all on the data side. Far from it. There are incredibly tight restrictions, and they're only going to get tighter if this proposal goes through.
And it's all anonymized, isn't it? I mean, it's all for the public health good. So people don't need to start squawking about Cambridge Analytica and that whole debacle.
Yeah, absolutely. I mean, it doesn't, just because something's anonymized doesn't mean necessarily that you couldn't identify a person in a data set who had sufficiently unique features. That's always been the sort of the argument against this. But there are so many protections on who has access to that data, how you publish findings, how you suppress small numbers, how you for instance, in our work, if we're handling patient level data for any reason and numbers get to less than 7, then we have to suppress all of those numbers so that you basically reduce the chances of identifying someone erroneously to as little as possible. And then there's all sorts of wider safeguards in terms of preventing misuse and controlling the data processing environment so that the data doesn't leave the NHS, and so on and so on. So the problem is that sometimes these people's fears are articulated in such a way that that things get lost. The reality of things actually, sort of, we speak about theoretical examples which are far removed from reality, and unfortunately that doesn't help the conversation.
I want to hear more about why you became disillusioned with your work as a GP. I know you thought, okay, next goal is what? But was there also a degree of doctor burnout? We hear a lot of talk about that, doctors feeling like pill dispensers instead of being given the time and the resources to actually do the digging, the root cause investigating, and focus on prevention. They're sitting for 8 and 10 minutes with someone who needs their help, and they've only got one issue that they can talk about. Was that part of why you thought, look, I can make a bigger impact in another way?
I think so. I came off the doctor production line whenever it was, 1995, I think, or thereabouts. And at that time, it was sort of before the European Working Time Directive. So it was easier to count the number of hours that you weren't in hospital than the hours that you were in hospital. Pretty much, I was back to back in hospital, slept 8, sort of 120, 130 hour weeks routinely, and sort of 72 hours on a stretch without any sleep. Suddenly you're faced with medical emergency in the emergency department, and you're not at your best at that point. I think no one would be.
I mean, the whole system relies on the doctor having that adrenaline rush, but surely that even gets topped out. If you have that over and over and over again, let's say you're working in the emergency department, my goodness, I don't know how a system can survive on that. I mean, it's like you go through school and you're doing those 120 and 130 hour weeks, and then you finally become a GP or hospital consultant and you're still doing them.
Yeah, that's right. And I think I was working at the time in the Scottish Borders, and so this is a massive geographical area. And so overnight, having worked full working day, overnight or at the weekend, if I was on call, then you would have to cover some vast areas that could take you at least, and we had police drivers to drive us around and things like that, so we could get efficiently from one house to another. But home visits might take an hour to get to, by road. And so, it was certainly challenging, but, in its own way, enjoyable. But I suppose I in those early years of being a doctor, I never really asked myself I would always do, as you always train to do in medicine, to do the best for the person in front of you. If the patient's in front of you, how can I do my best to help this person resolve their problems, or sometimes help them resolve the problem for them. And I didn't really, I hardly stopped to think, how did this person come to need to see me today in the first place? And it becomes a bit of a tidal wave, actually. And we've experienced this in the pandemic, and it really is literally like that we have a vast number of people waiting for treatment at the moment. And I think that just taking the approach of, how can I fix this person up? How can I give this person their hip replacement, or whatever it is not sustainable. It's clearly not sustainable. And we can't afford that health service. We have to get serious about prevention. We have to get serious about asking the question, why did this person end up needing to have this procedure in the first place? And
so what could we change about the education of our doctors? It's a question that's being raised in all the developed world, because they get, 20 seconds, a couple of lectures on nutrition, and prevention is rooted, 80 to 90% of the plagues of prosperity diseases, the cardiometabolic diseases, are lifestyle-led. There might be a little bit of genetic input around the edges, but, we need to work as a global team, really, to change the paradigm. How do you see that happening?
Gosh, it's got to happen at so many different levels. If I stick to my turf, which is outcomes measurement, we're so, even just on outcomes measurement, we're so used to measuring the outcome of a hip replacement rather than the outcome of the condition. So osteoarthritis in that case. Most of our measures of performance are, did we do the fastest, cleanest, safest hip replacement? And everything is sort of driven around the intervention, which ultimately, yes, it can be transformative, but ultimately that's a tiny fraction of the person's life living with, in this case, osteoarthritis. If we start to measure the outcomes of the condition, then we can think, oh, hold on a minute, can we get a more effective result if we use a variety of different approaches, irrespective of the cause? In some cases that might be addressing certain features about someone's lifestyle in terms of how they exercise and so on. But even if they've already got sort of established osteoarthritis or joint damage, there's so much that can be done by alternative therapists in terms of not alternative, but non-medical therapists, so physiotherapies, OTs, and occupational therapists, and so on, that actually can many times do far more than a surgeon with a scalpel, and really let's try and reserve the sort of the more extreme ends of what we do in medicine for the people who we're absolutely confident can't be helped in other ways. But I think just even having the right mindset around not just measuring outcomes of procedures, but thinking about the whole person, thinking about all of their care, not just the care that they receive in this hospital.
Well, it's like, we have to get ultra-processed food. I mean, that's at the root cause of a lot of these conditions. We have all kinds of, yes, it's anecdotal evidence, but it's also, people like Dr. David Unwin and Dr. Asim Malhotra, they're making great strides in showing that, as Hippocrates said, food is thy medicine. So we need to be starting there so that we don't have to have so many people going to the hospital with these avoidable diseases.
I think that's absolutely right. I think there's so much we can do particularly on the nutrition side of things, that I think where we do seem to have lost our way, particularly in parts of the Western world in particular.
Well, I think we're only, I read a chart recently, we're only second to the United States in terms of the share of our caloric intake. It's 50% in the UK of the diet is comprised of fake food, ultra-processed, manufactured rubbish in plastic, in cartons. And in the United States, it's 60%. And, 80 to 90% of people are pre-diabetic. They're setting themselves up for these chronic lifestyle diseases. So we need to attack that. And then you can start maybe broadening out your metric so that you can measure and get that component worked into the prevention aspect of healthcare delivery.
Absolutely right.
Now, getting back to OBH, how do you want to grow that? I mean, where do you see your company going? Right now, you're what, team of 15, is it?
Yep.
And what are your ambitions in terms of getting healthcare delivery changed into this prevention mode?
Well, OBH is growing, and that's great. It's telling us that we're sort of pushing on the right buttons. We're focusing on the right challenges, and our work on Healthspan has been a great challenge, and it's been great to get to grips with that. And I'd like us to do more of that. I suppose in terms of where we go, I think I'd like to make sure that we stay upstream. At least half of our work is focused on that healthy, well population, on really, really understanding that population and why people are becoming sick for the first time, and starting to really dig into the data around that to see if we can alter people's trajectories of illness. And just because someone does have a single long-term condition, is it inevitable that they end up with multiple long-term conditions? Are there patterns that we can see within the data around conditions which cluster together? That's an area of research and development for us in particular. And are there sometimes those conditions which can lead to more conditions? At OBH anyway, we call them gateway conditions. So researching some of those gateway conditions, are there things which, if we can address and nip in the bud and help, get people back into that healthy, well cohort, can we then stop them from progressing to 4, 5, 6, 7 conditions down the line? Or can we delay that? Maybe prevention is, in the first instance, for some of these conditions, too much to hope for. But if we can delay that for 5 or 10 years, for instance, then the overall impact over a life course of those subsequent conditions will be markedly reduced. So we're doing work with King's College London in a research partnership with Guy's and St Thomas's Foundation, which is a charity. And we're researching the sort of journey from one to many conditions. And is it possible to disrupt that once you start seeing people sort of wobbling in their health status?
Well, I guess if we can across the board get the government to really activate its levelling up goals, we could see some of the social determinants, the environmental breaks on this, the inequity that is built into the system, that can be attacked as well.
Absolutely. And I think at the heart of that work, particularly with Guy's and Tommy's Foundation, is precarious housing, precarious employment, those kinds of drivers that we're seeing in the data, really accelerating people's journey from one to many long-term conditions. So if we can really, really address that agenda, then I think we can slow down at the very, at worst, slow down the journey to many long-term conditions, and ideally prevent. So that's really, really a key area of focus for us. But I'd say more sort of broadly, I think certainly in the UK, there is a move towards this more person-centered healthcare. Now, I know that those words are used quite a lot, but mean different things in different places. But I think people who are not from the UK sometimes look at us and scratch their heads a little bit when they see how our NHS is set up, because it's not set up around individual hospitals. In fact, quite the opposite. The GP is very dominant in healthcare delivery, and the NHS is a partnership of organisations spanning, whom you'll interface with, many different organisations when you're having care from the NHS. And that some people struggle to sort of get their head around that when they're looking at that from the outside. I think for us, the move away from sort of just thinking about individual institutions and thinking more about a person's conditions across all of their care, wherever that's provided, that's sort of more philosophically where we want to be heading, both as a health system, and we want to support that as an
Yes, that holistic approach where all the dots are joined, and it's precision nutrition, personalized healthcare. We need to increasingly shift toward that end.
Exactly.
Well, Dr. Rupert Dunbar-Rees, thank you so much. Founder, CEO of the UK's outcomes-based healthcare, GP by background, public health innovator of distinction. I should say, congratulations, you just won an innovation award. Before we go, tell us about that.
Yeah, we were absolutely chuffed to bits to receive one of the Queen's Awards for innovation for 2021. So you can apply for it across any industry, and we were selected for healthcare innovation. So we're absolutely thrilled, and it's a great.
And that's for the work you're doing at defining and measuring Healthspan, or was it for a particular specific piece of work?
It's for our work generally, but it was the Healthspan piece, I think, which was particularly what the award was centered around. So we were absolutely thrilled, and the team were absolutely thrilled. Thanks.
Well, fascinating work. Fantastic. Rupert Dunbar-Rees and his team are all about defining and measuring what works to move us away from a sick care health system model to one of prevention, realistic ways to lengthen health span and maximize bang for healthcare buck as we adapt to the permanent demographic shift to an older population. Many thanks for your company, your kind reviews, and your podcast-sustaining donations via that big pink button on my website. SusanFlory.com is where you can go if you want to pitch in. So, final goodbye to you, Rupert. Thank you so much for coming on The Big Middle.
Thank you.
Bye-bye. See you next time.